تعرفي ويكند وما البرزنتيشن تكون طويلة مرة. طيب السلام عليكم ورحمة الله، جمعة مباركة. We will talk about brain tumors. However, it is a large subject to talk about. So I will try to mention the most important things to all healthcare provider, not only for physician or medical student. I will talk briefly about classification and grading system for brain tumors. We'll talk about the most important pathologies, etiologies, clinical manifestation, investigation. I will touch briefly on the most common brain tumors in adult and pediatric. And here we go. So this is a short video for a patient, 32 years old, with insular tumor, which is deep tumor for what we consider deep tumor. So this patient, she was operated before, and they will use the same scar for the surgery. So this is the position usually we put for a patient. However, because of the tumor location, we have to be careful about the speech and language areas. So she will be awake during the procedure. So as we can see that the patient is talking during the procedure, so they can test the area for the speech. So the patient, when she have a stimulation for the area of speech, she will have what we call speech arrest. And then we will test the language area. So the language area, it is the area where the patient can understand what he sees. So they are showing her multiple pictures. So if this location that he is testing is the location where the language is, the patient will have what we call hesitation. So in the other location, which is the speech location, they will have speech arrest. For the location where they are understanding the meaning of the word or the meaning of the picture, they will have what we call hesitation. However, during the testing, both locations were not the location of speech nor for language. So this is a safe area for the surgeon to proceed with his surgery. So I will allow now the speaker. So MCA is the middle cerebral artery, which is an important artery to supply the brain. And this is the difficulty in this kind of tumors, that it is deep, so it has a lot of related complication if we are not experienced to do such a procedure. Okay, now we'll talk about the classification, the last classification for CNS tumors. It is very sophisticated classification. I don't want to make it very difficult for you. So for that, I will make it very simple. We have to divide it either related to cells or related to location. So for cells, we have, as you all know, for central nervous system, we have astrocyte. So from astrocyte, we have diffuse astrocytoma, we have glioblastoma, we have diffuse midline glioma, and the rest. From oligodendrocyte, we have oligodendroglioma, either the anaplastic or the ordinary type. And we have ependymal cell, which contain ependymoma, subependymoma, and the rest. Then in relation to location, we have choroid plexus tumor, and we have tumor from pineal gland, and from the origin, we have embryonal tumors. Furthermore, we have cranial and spinal nerve tumors, and we have meningiomas, which is, we are talking now about the origin of the tumor, and mesenchymal non-meningothelial tumors. We have melonic tumors, lymphomas, histocytic tumor, and talking about the origin of germ cell tumors. And again, about the location, we have cellular region and metastasis. So this is the main categories for brain tumor. Each of this category, we have multiple tumors, okay? Now we'll talk about grading system. So brain tumors is divided to 4 grades. So either grade 1, which is the most benign lesions, and 2, which is more toward benign, 3, which is more toward malignant, and 4, which is the most malignant tumor. So for benign tumors, when we talk about tumor as a benign, we are talking about usually the course of the lesion, the natural history. So if there is a recurrence after surgery, if the patient will need radiation or chemotherapy, and all of these with exceptions. So some tumor, it is grade 1. However, chemotherapy is very effective for this kind of lesion. And we have a grade 2 tumor, which will progress, as we will talk later about diffuse glioma. It is grade 2, however, they have a midline transformation. And we have grade 4 tumor, which is malignant. However, with surgery, chemotherapy, and radiation therapy, like if we are talking about medulloblastoma, it is grade 4. However, we can reach cure in this kind of particular lesion. So the tumors are not, by grading system, they are not the same. So we have lesions that are grade 4. However, with the treatment, they can be cured. We have lesions that is a grade 2. However, even with treatment, they will progress and have a transformation natural history. So grading system shouldn't be taken without a context of the pathology, okay? And now I will give you just a repetition what I did, but now we'll talk about only common tumors that we saw in our clinical practice. So from astrocyte and oligodendrocyte, we saw diffuse astrocytoma, glioblastoma, diffuse midline glioma, oligodendroglioma, and pilocytic astrocytoma. And from ependymal cell, we see ependymoma, choroid plexus tumors, and pineal gland tumor are common. Also, we see them a lot in our clinical practice. And from embryonal tumor, one of the most common tumor that I would like you to know is medulloblastoma. And from cranial and paraspinal nerves, schwannoma and neurofibroma, they are very important tumor to know. And meningioma, also one of the common tumors I will talk about later. From germ cell tumors, germinoma and teratoma are common. From cellular region, and to know what is cellular region is where the pituitary gland is. So the sella torsica. So this is the location of sella. Okay, and the most two important tumor is craniopharyngioma and pituitary adenoma, and of course metastasis is very important to know. Okay, so we talk briefly about classification and grading. I know it's kind of boring, so now we'll talk about something more interesting. So we'll talk about the etiology. It is very, very common to hear about causes of brain tumor through the social media, through articles, through books. However, there is a lot of claiming regarding a lot of causes. But to be more scientific, we have two major causes of brain tumors. One of them is radiation. So either radiation that related to bionuclear weapons, or it is radiation that we use for treatment or for scanning. Radiation in general is a known cause of brain tumors, either malignant brain tumors or benign brain tumors. Actually, even in cases where we use radiation in younger age, like medulloblastoma, it is common to see, not uncommon, sorry, to see meningiomas developed in those patients. So we treated them from medulloblastoma at age of 4 or age of 5, and later on in life at age of 15 or age of 12, some of these those patients, they grow up benign tumors, and unfortunately sometimes it is multiple, and some of them are difficult to reach. So radiation, it is very common cause, one of the common etiologies of brain tumors. And the second cause is genetic. Either we are talking about genetic in relation to well-known syndrome, or genetic that relate to tumor suppressor gene mutations. So this is 3 examples of syndromes that we deal with that may cause brain tumors. And this is, I'm sure that many of you know that saw this picture before. This is a case of neurofibromatosis type 1 with multiple cutaneous neurofibromas. And this is a patient with neurofibromatosis type 2 with bilateral vestibular schwannomas. So they have benign tumors affecting the cranial nerve number 8. And this is a patient with adenoma sebaceum, which is part of the triad for tuberous sclerosis complex, along with seizure disorder and mental retardation. And the third cause, which is unknown, there is a lot of claims that either cell phones, either that kind of foods that can cause type of cancer, and a lot of traditional beliefs that brain tumor can be caused about something a lot of you heard about already. So if we talk about the cell phone, there is multiple studies actually done about the relation between cell phones and brain tumor. However, there is no study that confirmed that using cell phones that can cause brain tumors. Neither any study confirmed that certain type of foods can be related to brain tumors. Okay. Now we are moving to talk about the clinical manifestation. Always, I believe that medicine is logic. So to make it very simple, the clinical manifestation, I divide it to 3. Okay, so either sign and symptom related to increased intracranial pressure, and I will back to this slide, or location, or production. So these 3, if you keep it in mind, you can predict the clinical manifestation for any tumor. Any tumor you have, you can predict the clinical manifestation. So let's talk about increased intracranial pressure. There is a theory called Mornokili doctrine that stated that the component of the skull contain a constant volume. And this volume contain brain parenchyma, blood volume, and cerebrospinal fluid volume. So the theory stated that, the doctrine stated that if you have increase in one of the component, you will have decrease of 2. What does that mean? So if we have a mass, and this mass will cause a decrease in the beginning. It will cause decrease in the cerebrospinal fluid volume and blood volume. Blood volume will start with venous and then arterial volume, and at the end it will affect brain parenchyma volume, as we said that the patient will have herniation. Okay, so let's make this one as an example. So we have a mass, and this mass affecting the volume of the brain. First, we'll have decrease in CSF volume, and then we'll have decrease in venous volume. And by affecting venous volume, it will have increase. It will give us symptoms of increased intracranial pressure, and I will talk about the symptoms later after I finish this explanation. After that, it will affect the arterial volume, so the patient will have ischemia and he will have stroke, and at the end it will cause herniation, and then the patient will die at the end if we did not manage the increased intracranial pressure. So this is the path that we have when we have increased intracranial pressure. Now back to the clinical manifestation of increased intracranial pressure. So it depends about the patient age. If we are talking about infant and young, usually the skull will continue to grow. So with continuation of the growth, a patient will have macrocephaly. He will have full anterior fontanelle or bulging anterior fontanelle. He will have kind of because of, as we mentioned, venous congestion, he will have prominent scalp veins. And then later on, if he has an older patient, they will start to have another manifestation. So they will start to have headache, vomiting, seizures. They will have decreased level of consciousness. And this is all of these symptoms are in relation to increased intracranial pressure. So number one, symptoms related to increased intracranial pressure, okay? And now we'll talk about the location. So when we are talking about the location, either it mean by location of the functional location, which is related to the brain function, or histological location. What does I mean? What do I mean by histological location? So we have symptoms related to the location of the lesion in anatomical background. So if the lesion in the dura, usually it will cause headache because the dura is sensitive to pain. So with the stretching effect, he will have headache. If the lesion in the cortex of the brain, he will have seizure because the seizure activity usually generates from the cortex. Okay, then we'll talk, if we are talking about the function, we'll talk about like if the patient have a lesion in the motor strip, he will have weakness. If he has a lesion in sensory cortex, he will have numbness. If he has a lesion affecting or compressing the optic pathway, he will have visual field defect. If he has a lesion that affecting the cerebellum, he will have a problem with coordination. He will have a problem with alternating movement. He will have a problem related to muscle tone. So it depends about the location of the lesion. So the patient symptoms usually give us a hint that where is the location of the lesion. And this is very important to know, okay? The third component is production. And when I am talking about the production, mainly it is related to pituitary adenoma. Why? Because there is a multiple lesions or multiple tumors that can affect pituitary gland, subtypes of pituitary adenoma that can affect the pituitary gland and producing hormone. So some of the patients, they have symptoms related to hyperthyroidism. Some of the patients, they have symptoms related to excessive growth hormone producing. They will have acromegaly. And some of the patients, they have excessive production of cortisol, so they will have a Cushing syndrome. So all of these hormones, they are giving or producing symptoms, okay? Or the other hand, that there is some kind of the tumor like choroid plexus papilloma, which is originating from choroid plexus, that they produce cerebrospinal fluid. When they produce cerebrospinal fluid, they can cause dilatation of the ventricles and can cause what we call hydrocephalus, which is active dilatation of the ventricles that cause increased intracranial pressure. Okay. So we finish now with clinical manifestation. Now I will talk about the investigation that we use for brain tumors. So in late 50s, you know, before the era of magnetic resonant imaging, before the computed scan, before the fancy tools that we have, they were using a simple X-ray. So simple X-ray, it is very useful tool at that age, at that period of time when the CT scan and MRI were not available. So what we can see by the CT scan at that era, with CT scan, they can see the calcification. So calcification will give you a density like a bone. See, this is the skull bone, and this is the calcification. So this is an X-ray for a patient at that period with choroid plexus papilloma with calcification. So calcification number one. Number two, they can, with this simple X-ray, they can have a hint about the tumor location. How they do that? They inject the CSF with air, so we call it pneumoencephalogram, and then the air will travel all the way to the ventricles. So the ventricles where the CSF is circulating. And this black is the lateral ventricles. So we can see the lateral ventricle. And then, as you can see, this is the midline, and the ventricle are pushed to the other side. So what they will get from this image, that there is a tumor here on this side, pushing the lateral ventricles to this side. Okay. And to be honest, nowadays we don't use X-ray for brain tumors almost at all. But we still use the X-ray for patients with a brain tumor and hydrocephalus, where they operated for treatment of hydrocephalus. So this is an X-ray for a patient where we have the ventricular catheter. The catheter will be inside the ventricle, and it will be connected to a valve. This valve will regulate the volume of the CSF that we took from the ventricle to be drained in the peritoneal cavity, okay, and to be absorbed in the peritoneal cavity. So this is mainly the mainly used for X-ray when we are talking about brain tumor. Now we'll talk about the CT scan. So CT scan, it is a good tool for us. As a neurosurgeon, we consider CT scan as our eyes. We see with CT scan because, you know, yes, we have, we examine the patient, we talk a history. However, CT scan is very important tool for us to decide what we are dealing with or what kind of urgency we have. So CT scan is very quick procedure. It took almost 5 minutes or less even. And then it will give us a hint what kind of disease that we are dealing with. Why we are using CT scan? Mainly we use the CT scan in emergency. We need to do a quick scan for the patient to know what's going on. So CT scan, it is good to show us blood. CT scan, it is good to show us calcification as an X-ray. And also CT scan can give us a hint patient have signs and symptoms of high ICP if he has dilated ventricle or what we call or like to call active hydrocephalus that need urgent intervention, or also can give us a hint of what kind of tumor we are dealing with. So, for example, this patient is a young patient, and he has a lesion that is high density in relation to the brain, and it is dependent on the age and location and hyperdensity in this scan. I can say that medulloblastoma is one of the differential diagnoses, even before getting the pathology. And on the other hand, also for this patient, according to patient age and the tumor location, and also the effect of the mass to the surrounding structure, I can say that this is a most likely meningioma. Why? Because it is high density also. And in this patient, I can see there is a dense calcification here, and it is cellular lesion, or cellular and supracellular lesion. And according to the patient age, I can say that this is a craniopharyngioma, or most likely craniopharyngioma. So CT scan, it is a good tool to use for differential diagnosis and also as a part of the management in urgent care. The gold standard for brain tumors is magnetic resonance imaging, MRI. So again, MRI, it is important tool to have more and more information about the lesion we are dealing with, and also it is a useful tool to be used inside the operating room. So back to this patient, the patient we saw his CT scan, and we think about craniopharyngioma. Now we are more convinced that this is craniopharyngioma. Why? Because he has cystic component, solid component, calcification, patient age. This is more likely to be craniopharyngioma. And in this scan that we saw that patient, we suspect meningioma. Now we are more confident to call it meningioma. Why? Because it has an enhancing tail, what we call dural tail, which is common to be seen in meningioma. And in that patient with medulloblastoma, one of the images, one of the sequence that we use in MRI is diffusion weighted images. And with diffusion restriction, we can say confidently that this is medulloblastoma even before having histopathology. Okay, so now we'll talk about the most common tumors affecting adults. And in the beginning, of course, we have to start with metastasis. Metastasis, it is the most common brain tumor. So if we are talking about the most common tumor in the brain, it is metastasis. Metastasis, it is the most common. And the most common tumor that we saw usually in metastasis is lung cancer. Why? Because lung cancer is the most common tumor. So lung cancer is the most common malignant tumor. And we can see breast, renal cell carcinoma, GI-related tumor, and melanoma. Why I highlighted melanoma? Melanoma is less common than lung cancer. However, if we are collecting the cases, melanoma cases, and see what is the most common organ that melanoma metastasizes to, it is the brain. So the most, if we have a multiple choice question that what is the most common tumor likely to metastasize to the brain, it is melanoma. But if we have a question, what is the most common metastatic brain tumor, it will be the lung. And this is applicable for adult. If we are talking about the pediatric age group, we are talking about neuroblastoma, rhabdomyosarcoma, and Wilms tumors. Talking about the management and prognosis of metastasis, it depends about multiple factors. The most important factor is the patient clinical status. So Either the patient is doing his daily function, or he is sick, he can't do his personal need, he is dependent to a ventilator, he have poor functional status, or in the opposite, that he can take care of himself and he is having very minimal neurological deficit. This is very important in decision making for metastasis. The other thing is patient age. Next is the number of metastases. So unfortunately, usually metastasis is not a single lesion. So patients have multiple lesions, and this makes it more difficult. So usually for patient with good clinical status, and he is younger age and his primary tumor is under control, usually we tackle the most symptomatic lesion. So the symptoms that it is causing, the lesion that causing symptoms is our target for surgical intervention. And then, of course, depending on the pathology, the patient will have further treatment. The mainly treatment for metastasis in the brain is radiation, either stereotactic radiation or whole brain radiation. The most common primary brain tumor is glioblastoma, which is, you will hear it a lot, GBM. But according to the WHO classification, it's called glioblastoma. Unfortunately, it is WHO grade 4, which is malignant. And what we see here is what we call butterfly appearance. So unfortunately, this lesion going through the corpus callosum, which is making a connection between the two hemispheres, and going through corpus callosum to the contralateral side, to the other side. Unfortunately, this is a very bad sign, and it makes the total resection of the tumor impossible. Usually, it divides according to genetic mutation background. I will not talk about this, but the most common location is temporal lobe and frontal lobe. And unfortunately, it carries very poor prognosis despite gross total surgical resection, chemotherapy, and radiation therapy. Majority of patients, they will have a recurrence within 15 to 8 months. And unfortunately, the natural history of disease is a killer disease. Next type of brain tumor we'll talk about is diffuse astrocytoma. As I mentioned, it is WHO grade 2. However, the natural history of this disease, that majority of them, they will have malignant transformation to GBM or glioblastoma. So even it is WHO grade 2, it is not a benign lesion. We can't say that it is a benign lesion. This tumor is commonly located in temporal lobe or posterior frontal and anterior parietal lobe. And as by definition, as it is diffuse, there is no clear demarcation. Yes, you can say that this is the white and this is the gray. However, either by imaging or by inside the surgery, it is very difficult to identify the tumor edges from the white matter from the normal brain. So that's why it is diffuse. And if we talk about the prognosis, depend about patient age. The younger the patient has better prognosis. The size of the lesion, size more than 6 centimeters, unfortunately, carry a poor prognosis, because usually with bigger size, it is difficult to achieve total resection, and also preoperative clinical status for the patient. This is the next tumor is oligodendroglioma. So now the current definition of oligodendroglioma depend about seeing the co-deletion of 1b19q chromosome. So before, we were diagnosing the oligodendroglioma by histopathology. And this is what we call fried egg appearance. So fried egg appearance is very common term that we use to describe oligodendroglioma in histology. Usually they present with seizure because, as we mentioned, we can see it is superficial, so it is cortical lesion. And because of it is cortical lesion, it will cause seizure. Usually frontal lobe is the most common location and has good prognosis because they respond well to chemotherapy. Next is ependymoma. As we said, that it is originating from ependymal cell, and ependymal cell is located in the ventricular system or in intraspinal canal. However, ependymoma can grow anywhere, even extraventricular ependymoma. It is a well-known pathology. In pediatric age group, usually we see it in the fourth ventricle, and in the adult, usually we see it in the spine, intraspinal. It is the common location. So usually it has good prognosis and with WHO grade 2. How we can tell that, as I told you, that MRI usually give us a hint about the pathology. In ependymoma, as we said, it is growing inside the, for pediatric, inside the ventricular area. So as we can see here, this is a coronal cut. So if we move anterior, we'll see the eyes like this. And so the cut is coronal cut, what we call coronal cut, okay? This is the ears, okay? So it is occupying the fourth ventricle and going lateral to foramen Floschka and going down to the intraspinal canal. So it is following the CSF pathway, which make the ependymoma as one of the top differential diagnoses by seeing these images. Next is choroid plexus papilloma. It is a benign lesion. It is originating from the choroid plexus. Usually in pediatric age group, left lateral ventricle is the most common location, and in adult, fourth ventricle is the most common location. And as I told you that choroid plexus papilloma is capable to produce CSF, and this will cause dilatation of the ventricle like this patient, and they will have signs and symptoms related to high ICP and active hydrocephalus. Usually the prognosis is excellent after total resection. Next is GERMINOMA, which is originating from germ cells. So by seeing this image, you can say that this is GERMINOMA by like 99.9%. Why? Because we have biennial and supracellular lesion. So if you have those tumors together, it is GERMINOMA until proven otherwise. And if we have GERMINOMA in pineal gland only, it will be more common in male. And the supracellular GERMINOMA by itself, it is common in female. Okay, but if we see both lesions together in one patient, this is most likely GERMINOMA. And for this particular patient, she was a female. Okay, it is the most common germ cell tumors, and the most common germ cell tumor happen in pineal area. Pineal area is more common than supracellular area. Prognosis is excellent. They are very radiosensitive, and usually biopsy will be enough in conjugation with radiation therapy to treat these patients. Next is schwannoma, which originate from the vestibular nerve, and they have a triad. So patient with these three symptoms, usually the first thing I have to suspect is schwannoma, so hearing loss, sensorineuronal hearing loss, tinnitus, and disequilibrium. So if I have a patient with these three symptoms, I have to keep schwannoma in mind. We saw the previous patient that he has a meningioma in almost the same location. Why we suspected meningioma here and schwannoma there? we have two hints. The first hint is hyperdense or high signal intensity in CT scan, and the dural tail, and the homogeneous enhancement. While in schwannoma, we didn't have the dural tail, and also the enhancement is not homogeneous. So it is here some black, gray, white. So it is not like meningioma. And the other thing, it is going through the canal, so it is following the nerve. The problem with schwannoma, it is a benign tumor. However, the location is not benign. So the location is nearby the facial nerve, nearby the brainstem, which make the resection sometimes associated with kind of complication like facial nerve injury, which is getting more common with the size of the lesion. We talked about meningioma earlier, and it is the most common primary intracranial tumor. What do we mean by, what is the difference between this term and the glioblastoma term? The difference that when we are talking about the glioblastoma, we are talking about the brain tissue, the brain parenchyma. But when we are talking about the meningioma, I think someone did not mute his microphone. Okay. Sorry. Back to our presentation. So it is the most common primary intracranial tumor. So when we said intracranial, it involved the arachnoid layer, the dura, the brain parenchyma. It involved all the tissue that in compartment inside the intracranial tumor. Okay, so originates from meningothelial cell in the arachnoid layer, common in female, and the majority of meningiomas are benign. For the next tumor, it is pituitary adenoma, which is involving the anterior pituitary gland. Anterior pituitary gland, we have a PITUITARY, which is another category, not in the same category of pituitary adenoma. The most common tumors are non-functioning, because it is divided to functioning and non-functioning, depend on the hormonal production. And the most common functioning pituitary adenoma is prolactinoma. For pituitary adenoma, we have a medical treatment. So for prolactinoma in particular, we have cabergoline, we have bromocriptine, which is usually help in management in prolactinoma, and sometimes even we don't need to do a surgical intervention for such an adenoma. Medical treatment will be enough. However, non-functioning adenoma, when it is symptomatic, or other functional adenoma, treated usually surgical, and I will not talk more detail about that. Okay, so we finish almost with the adult brain tumors. So I will talk now about pediatric brain tumors. First one is medulloblastoma, which is the most common malignant brain tumor. And it is usually the age of the patient less than 9 years. They have drop metastasis, and when we talk about drop metastasis, we mean that patient has a lesion in the cerebellum, and drop metastasis mean that he will have more lesions in the spine, spinal cord, so cervical spine, thoracic spine, and lumbar spine. So this is what we call drop metastasis. Treatment usually surgical resection, chemotherapy, and radiation therapy. Those patients usually they do well, majority of them, with the treatment. However, there is further classification for medulloblastoma, for classification, Synek-Hodgehog, WNT, group 3 and group 4. I will not talk a lot about them because there's more details. We don't need them. So, however, just to give you a hint that some of patients, biopsy will be enough for them to have a tissue diagnosis. We don't need to achieve a total surgical resection, and they will do well with chemo and radiation. And other patients, even with total surgical resection, chemotherapy and radiation therapy, they don't do well. However, majority of patients, they don't do well. We are talking about younger age group, so less than 2 years with mutation and drop metastasis. And I don't want to talk a lot of detail. I get biased because I'm pediatric neurosurgery fellow. Next is pilocytic astrocytoma. It is WHO grade 1. Most common location for pediatric age group is the cerebellum. 1/3 to 45% of these patients, the tumor residual will regress after surgery. So even if you did not achieve a total resection, 1/3 to 45% of them, after surgical resection with follow-up, even if you leave part of the tumor without chemotherapy, without radiation, it will regress. And there is some case report of completely disappear of the tumor. They have excellent prognosis, and this is one of the common and most benign tumor affecting the brain, which is pilocytic astrocytoma. Craniopharyngioma, it is common in pediatric, and also, however, it occurs in adult around age of 55. It can occur in adult. It has usually cystic and solid component, and they have calcification. This tumor is WHO grade 1. It is a benign tumor. However, because of the location of the tumor, because of the surrounding structure, because of the sticky nature of the tumor, especially when we are talking about pediatric, it is not behaving as a benign tumor. Why? If God forbid, hypothalamic injury occurred during surgical intervention, and the more surgical resection you do, or the more radical you are doing surgical intervention, you have a higher risk to have a hypothalamic injury. Hypothalamic injury will devastate the patient's life. So majority of them with radical resection will go with lifelong hormonal therapy. They will have a sleeping problem. They will have hyperphagia, which means that they can't prevent themselves from eating a lot. They will have a behavioral and psychological, neuropsychological problem. So now, when we are talking about craniopharyngioma, the consensus for treatment is partial resection, radiation therapy. Most of the pediatric neurosurgeon, they agree that total resection for craniopharyngioma is not indicated anymore. Why? Because those patients, they are young. So if you destroy the patient hypothalamus at young age, it is not a killing disease. Craniopharyngioma is a benign lesion. So he will lifelong, however, with poor quality of life. So now the majority of surgeons, what they will do, they will try to do a partial resection and then do a radiation therapy, either radiation therapy following the surgical intervention or delay fashion of radiotherapy. According to the multiple reports for recurrence of craniopharyngioma, most of the neurosurgeons, they recommend lifelong follow-up. And for myself, I saw two unfortunate cases, that a recurrence happened, one patient after around 15 years and the other patient after 10 years. So you can imagine that patients have excellent outcome after surgery and radiation. Follow up for 1, 2, 3, 4, 5, 6, 7, 10 years, and then they have a recurrence. And unfortunately, for both patients, it was a bad recurrence. So it is a benign lesion, the WHO grade 1. However, it is behaving as a malignant lesion because of the location and the nature of the tumor. So this is what I am talking about when I said that, yes, it is a grading system. However, it doesn't mean that it is totally reflecting the natural history of the disease. Diffuse midline glioma, unfortunately, it is one of the saddest tumor that we have in pediatric, which is unfortunately killing disease with no treatment, to be honest. There is no treatment. Surgery is not indicated. There is no role for surgery, even no role for biopsy. Because by definition, this kind of the tumor can be diagnosed by imaging itself. So this is the brainstem, in particular the bone of the brainstem. So it is, it is like a fatty bones, and this is enough for diagnosis. So it is like a swelling in the bones. It is enough for diagnosis. Radiation therapy, it is usually palliative, so it doesn't affect the patient prognosis, and unfortunately, majority of them, they will die within 2 years. Usual presentation is cranial nerve abnormality, mainly the lower cranial nerve, and the cranial nerve in relation to the location. The age of presentation between 5 to 9 years of age. Okay, so we are almost done. I have only what we call bonus slides. So this is few points that I would like you to remember. So metastasis is the most common brain tumor, and the most common primary is lung. The second point is glioblastoma is the most common primary brain tumor. Third point, meningioma is the most common primary intracranial tumor. And the tumors that has a high signal, or what we call hyperdense in CT scan, to memorize it, it's 4 M's: meningioma, medulloblastoma, melanoma, and malignant lymphoma. Here we reached to the end of our presentation. I hope it is informative, and I believe I talk already 30 minutes. Sorry, 1 hour. So I am so compliant with the time. I'm happy to receive any question, comment.
الله يعطيك ألف عافية، ما قصرت. شكراً على المحاضرة الجميلة هذه. وإذا ما عليك أمر تنتبه للشات، في سؤال، وكمان خانة الكواتشن فيها سؤال.
Okay. So ساعات تعليمية تعليم طبي لا ما في. طيب, 2 weeks ago I had a 14-year-old patient with diffuse high-grade glioma and brainstem with poor prognosis. What is your opinion about this case? Unfortunately, as I mentioned, diffuse midline glioma is one of the saddest tumor that, as a neurosurgeon or pediatric neurosurgeon, we give up. We don't do surgery unless patient has hydrocephalus, dilatation of the ventricle, and we have to insert CSF diversion, like as I show you, the ventricular peritoneal shunt. This is the only management that we can offer for the patient. Currently, there is no standard of care chemotherapy, and radiation therapy, as I mentioned, it is kind of palliation. So this is my opinion in regard for brainstem. Rawaf, doctor, sorry for interrupting, but I have a question. Meningioma will not affect the facial nerve. Meningioma or cranial nerve in general, it is affecting mainly the sheath So it is not affecting the nerve itself. Nerve itself gets affected by schwannomas, by neurofibromas. This is the most common tumors affecting the either cranial nerve or spinal nerve. Okay, I hope this address your question. Okay, what about the question area? Ahud, I can't see the question for question and answer.
مو راضي تفتح معك؟
لا ما if you kindly can read the question for me, I will be.
اوكي انا هحط لك في الشاتنج عشان تقدر تشوف.
I can. Yes. Thanks, doctor. Could you speak about cerebral mutism? Why it is more for a certain type of tumor like MEDULLOBLASTOMA? What is the cause behind it? Okay, excellent question. Very excellent question. So cerebral mutism, it is kind of just I will share. Yes. So cerebral mutism, it is kind of complication that we have mainly with the after surgical intervention. It is not in certain pathology. However, it depends about the size of the lesion. They have that there is a correlation between size of the lesion and cerebral mutism. Other thing, they said that some studies talking about how much you resect from the vermis when you approach the tumor. But the main agreement about the etiology of cerebral mutism, it is interruption of cerebellothalamic tract. So when you affect this tract, which is between the deep cerebellar nuclei and the thalamus, this is the most likely time when you have a cerebellar mutism. For those who are not aware about cerebellar mutism it is a combine of symptoms that have that affecting patient which continue. Sorry, it's kind of symptom that he have muscle hypotonia. He has an ability to emotional liability. He have difficulty in speech and in communication. And usually this is happen usually day 2 to day 3 after surgical intervention, and sometimes it take weeks, unfortunately, to improve with the time. There is no treatment given for this condition. Some patients, they have weeks to improve with physiotherapy, speech therapy, and some rarely they talk a month to recover from this unfortunate consequence from surgical intervention. Okay, so any more question?